Now, I invite Dr. Stephen Groft, Office of the Rare Disease Research, NIH, and he's going to talk to us on integrating global community partners for the diagnosis and treatment of rare diseases. Steve, it's you.
Okay, thank you, Ramaya, and I will try to share the screen and to bring up my slides.
You can do it, sir. You can do it.
Okay.
Yeah.
I hope.
Yes, sir. It's good. It's good.
Okay, there we are. We'll try this. Thank you very much for the invitation to join you. And I'd like to talk today a little bit about the need for partnerships and collaboration. One of the key words that was mentioned earlier in the discussions today. Without that, we just do not make the advances in rare diseases that we need to have for treatments and diagnosis. So I will start with these. So let me first talk about some of the misperceptions, and I will go very quickly through these, and the slides will be available. Some of the misperceptions that we deal with all the time is that very few people have the condition. We're unable to recruit for clinical trials. There's little or no information available. There's no academic or industry research interests, and very few treatments are available. Many of these issues that we see here are issues that we've been working on, trying to improve, as we've heard from the first two speakers, about improved access to rare disease-focused clinicians to really give hope to the entire populations, the families, the patients, and even the clinicians who have to treat these conditions when it appears there's nothing available. When there have been tremendous efforts made by different organizations, particularly the many patient groups that we deal with here in the United States, organizations such as NORD, Genetic Alliance, Global Genes, and other parts, IORD is a very strong factor, organizations in India that have focused on the rare diseases. And we find that indeed there is quite a bit of information available. It's a matter of finding it and centralizing it, but a lot has been done, and I'll have some resources at the end of the presentations for you to look at that I'm probably sure most of you are aware of to begin with. So here we are, why have we come to the point now where there is an increased research awareness in rare diseases and orphan products? And I think what it is, the fact is that there's a greater recognition that rare diseases represent global public health issues, and that in order to be successful in addressing these issues, you need partnerships, and they have to be available to gain access to the patients and the families. We've seen in the last several years tremendous expansion of the role of the patient advocacy groups and the acceptance of patient advocacy groups as research partners. The patient groups are quite responsible for improving the patient recruitment and the support of the patients during the clinical studies. We've also seen a greater increase of patient risk and acceptance of risk tolerance issues that before people say, well, I'm not sure if I want to use this medication or not. I think the hallmark of the rare diseases community, the patients, has always been a willingness to participate in clinical studies and to accept the risk when there are so many unknown factors involved with a new drug. We've also seen an increase in the number of research investigators experienced in clinical trial design with small populations involving multi-site studies, just a major increase in understanding of how to do these studies and how to implement them throughout the world. We've seen an increase in the flexibility and a regulatory emphasis on rare diseases by the regulatory agencies throughout the world. Certainly, as was mentioned, the increase in information technology use is essential. The internet access, social media, crowdsourcing, blogs, mobile apps, all of these technologies are available, and the patients are using these, the families are using these to communicate and to share information. I think also what has happened, the expanded publicity about undiagnosed diseases, the difficulties in getting diagnosis, genetic testing, possibility of gene therapy, gene editing, the advent of precision medicine, movement into precision medicine, particularly for the rare diseases, something we've all felt has been present for many, many years, even before the term was coined. And one of the more important things that we sort of forget about is that there are good business models for rare disease and orphan products to move products into the market. So in order to do so, I would like to put out there a position that we have to continue to focus on patient-centric partnerships. When you look at all aspects of rare disease, the research, the development of products, the interactions, all of these partners here that you see here, one organization that had contact with all of these groups are the patient advocacy organizations. They are the ones who interact.
Yes, yes, sir. I just want to remind.
They're the ones who do the medical specialists or primary care providers. We need their participation and leadership, but I think we all have to remember.
Thank you very much.
We want to work with them, and sometimes our expectations of patient advocacy groups are tremendous, and we have to make sure that we provide the resources for them to function the way they are capable. And I'll have a slide on the regulatory agencies talking about patient-focused drug development as we go forward too. And so just extremely important that we provide that acceptance of the patients as partners, and they are the center of what we're doing with our research. So here are some of the roles that we talk about and we ask the patient to do. I think any of us in our real life, if we were to look at this and say, gee, to do all these things would require a great deal of money. And these activities do require a lot of money, but we find so many volunteers who are willing to provide these different activities that make an increased emphasis possible for the rare diseases. We talk about them forming medical, scientific, and patient advisory boards. We ask them, the patient group, to support research, support new investigator training programs. We provide ready access to social media and educate the public healthcare providers. They also provide a great deal of time in translating the research advances that all the research community provides. They're the ones who often translate to the patients and the families. They organize research-based conferences and meetings. And again, I would highly recommend all researchers or clinicians working with rare diseases to make themselves available to patient advocacy groups. Join their meetings and provide your knowledge and expertise. They are probably some of the better recruiters for any of the clinical trials, but also many of the patient groups and the organizations develop patient registries, support the collection of biospecimens through various studies, they support natural history studies, and again, help recruit for the clinical studies and clinical trials. So some of these things we just would like to talk about, and I could go on, but I will skip through several of these because we talked about them. But I think the third bullet there, to address the psychological, sociological, and financial impact of a lack of a diagnosis and the lack of adequate treatment for rare diseases, the impact upon the families, patients, financial. We do have to be aware of that, and I was happy to hear the previous discussion presented about meeting these needs also, and the discussion about interpreting the genomic sequencing to come to a quicker diagnosis for the patients and the families. We still lack ICD codes for most rare diseases, and this certainly presents certain problems in monitoring the diseases and coming up with an adequate prevalence for the rare disease. And I also think that one of the challenges we have is in the regulatory field, where each country works differently on a regulatory application for a new drug or investigational new drug application. And I think it would be good if we could have the international collaboration and harmonization, the ICH, and the International Coalition of Medicine's Regulatory Authorities, the ICMRA, to address the current and emerging human medicine regulatory and safety challenges for rare diseases. It seems like we should be able to do a better job of addressing the issues and the needs of researchers in rare diseases and the applications that are coming in. And there are alliances that have been established, and it would be, I think it would be very, very beneficial to the rare disease community to have these organizations address this issue in great detail. So some of the other challenges, from a scientific perspective, is to establish the comprehensive global data collection, data entry, data sharing procedures that are necessary for the rare diseases using common ontologies, common data elements that we've talked about. But we have to understand, when we go into many of the countries throughout the world, there needs to be a better understanding of the cultural, ethical, legal, and social issues in that particular population as we move through. And all the time protecting patient privacy and avoiding the stigmatization that sometimes occurs with the rare diseases. Another major challenge is expanding the awareness of rare diseases to everyone, including those who are low income, have poor literacy, minority ethnic status, and may not have access to care and treatment or information. We want to look at indigenous populations and people living in underserved and marginalized urban and rural areas. So all very, very important. And with that, the challenges that have occurred, particularly in the last 2 to 3 years with COVID, the advances in telehealth and telemedicine, we've made some great leaps now to utilize these resources. And I hope that we're able to continue utilizing the resources, expanding the resources to have the expertise come to the patients rather than the patients having to travel hundreds, if not thousands of miles to gain access to knowledgeable clinicians. And so to do this, we talk about the value of natural history studies and patient registries, but we do have to answer questions about what makes patients different and why are the diseases variable. And many times it is because of the genotype, the genetic differences in patients. We have to do a better job of understanding this. In any of our work, we try to identify who are going to be the responders to therapy, and then can we predict who those responders are going to be based on our knowledge that we gained through the earlier studies. And as we know, not all patients respond to treatments the same way, and getting back to the variability in patients, we have to have that understanding to make the application stronger to the regulatory agencies, that we know who the responders will be, and to identify them more readily. And as we know, precision medicine is here now. So we talk about the collaborative research partnerships. We want to utilize the strength of academia, government, and industry, venture philanthropy, and patient advocacy groups, and public-private partnerships to really provide that collaboration that is necessary. We had the European reference networks were mentioned earlier. We've had activities here in the United States in rare disease clinical research networks, but we do encourage the collaboration in consortia and international networks as we move forward with rare diseases. Last several years has seen an increase in different clinical trial designs, many times involving a smaller number of patients, utilizing decentralized clinical trials, master protocols, basket and umbrella trials that we can employ multiple agents in one study for treatment, or multiple diseases with one treatment. So I think there are newer ways of addressing rare diseases, more diseases at one time rather than just one disease at an individual time. So the bioinformatics and artificial intelligence that I spoke about, certainly we want to maximize those advances, and very, very important. And what we've noticed with our own rare disease clinical research network here is that we have to maintain trust among the investigators, and that involves sharing data, sharing publications, and the ability to co-author papers is extremely important. And again, I think we want to look at the entire research continuum from basic research to clinical research, translational research as we move forward, because these are all essential to think about when we're looking at a compound that or a drug that will be used for a rare disease. This is a little bit of a process that I use. I won't spend up too much time, but really just to reflect that we sort of can go in a circular pattern here, starting with the development of a patient registry. And you see, we move through, and I mentioned several of these things, the biospecimen repository, the natural history study, and we use these also for repurposing purposes to look at off-label uses for studies. We want to generate the research hypotheses, and this leads to clinical trials, interventions. We see a major emphasis on real-world evidence, and then post-approval studies. And so essentially, we start with the patient registry, go around the circle, and we end up back here with many times with post-approval studies required post-marketing surveillance. So I won't spend too much time because you've heard these terms, but I do want to mention that the regulatory agencies have provided a great deal of emphasis on novel approaches and emphasis, particularly to the rare diseases and orphan products, the fast track designation, the breakthrough therapy designation, accelerated approval. You've heard of PRIME, you've heard conditional marketing approval throughout the world. These are major changes from a regulatory perspective. And as I mentioned before, the ability to have patient-focused drug development, the patients can participate in meetings with the regulatory agencies before the approval to provide their impression of what is important with respect to the clinical trials. And I think even with our research network, we've always tried to involve the patients to have them participate in writing not only the informed consent document, but also to review the clinical trial protocol and see if this is something they really can meet the criteria for participation and how to make it better. We've gone through and talked about many of the unmet medical needs associated with the rare diseases as we go into discussions with the regulatory agencies. And we talked about acceptable risks. And these are significant issues when it comes from a regulatory perspective. And we suggest, and even the agencies, regulatory agencies, say, come to visit us early and talk with our staff, discuss with us often what are the needs and how things are moving and what are your needs. And you see many of the other incentives that are made available to sponsors of orphan products. So I'll just briefly mention these different activities within the NCATS here at NIH, information on patient registries, a toolkit, how to function as a patient advocacy group in different stages of product development or research. Very, very important. We've had an emphasis on natural history and intervention studies through the rare diseases. And I just briefly mentioned two programs. One is called PAVE. It's a platform vector for gene therapy, and we're attempting to look at 4 different diseases at a time. Can we add 4 different diseases into a clinical study using the same platform, using the same vector, route of administration? So PJ Brooks in the office has been working on this, and we've seen some of this already with the rare diseases and some of the cancer treatments. And again, often we find the experience in the cancer research area is applicable to the rare diseases. And another one that PJ is working on and doing this with IRDiRC is looking at what is the current classification of diseases. And traditionally, they're based on clinical manifestations. And PJ and others have been talking about how do we look at the underlying genetic etiologies? Are these approaches, say, for example, these 5 areas here, are these possible that we could start to group diseases differently into different nonsense mutations, missense mutations, all of these different activities that we now are looking at it from a different perspective, molecularly, than what we did looking at the phenotype. And I think that is what PJ will be working on with IRDiRC, and we'll be hearing more from IRDiRC on this later on. And I'll have a real quick slide to reference that organization. So I know I'm running short on time here, so I do want to mention the Undiagnosed Disease Network that was initiated back in around 2008 here at the Clinical Center at NIH, and now has expanded to the network throughout the United States, and even more, the Undiagnosed Disease Network International, and the link there to the UDNI. I really recommend folks look at this and perhaps join it. We've had a conference in India a couple of years ago, very successful, and we always are looking for partners. And I mentioned IRDiRC before, and I know I'm running short on time, so I will just refer you to the website to look at this, but lofty goals of trying to get in the year from 2017 to 27, 1,000 new therapies for rare diseases to be approved. And also, I think the other one is to trying to get a diagnosis within a year of coming to the attention of medical specialists if the disease is known. And then also to look at how are we going to assess the impact of diagnosis therapies on rare disease patients. So some of the resources that are available, and you probably have gone through these many times, such as PubMed, the Orphan Product Designations and Approvals. I did not include the European Union, mostly because of the slide emphasis here in the United States. I'll just include this information, and you can find how much is being, how much the level of support for various research conditions and rare diseases within the NIH structure. Also, the clinicaltrials.gov for ongoing and planned and completed clinical trials. And two sources of information that I think are critical to search is OrphanNet and the Genetic and Rare Disease Information Center. So one last comment is we've undertaken a major program in Latin America to look at the rare diseases, and you can see here the various priorities that we're looking at and considering for the rare disease, including the research infrastructure, the expanding roles of patient groups, access to diagnosis, access to clinical care and treatments, research collaboration, and so forth. We also want to look at how we can expand the manufacturing capacity and capabilities in these countries. So I just want to draw your attention to a conference and a paper that was published from ICORD. It was a call to action for the Protea Declaration for Rare Diseases in Developing and Developed Nations. And again, to look at this and to see what is applicable to each other, I think is very, very important. And, another one we did before was in Japan back around 2011. So I think I will just do it. I know I'm out of time, so I will finish with that. But I did want to thank Ramaya for all of the work that he's done for so many years with his commitment to rare diseases and to India. So with that, I will thank you. And please, if you have questions or any other issue you'd like to discuss, please contact me. Even though I'm a special volunteer at NIH, I'm still able to keep the email address. So please do not be reluctant to contact me or to work through Ramaya to get in touch with me. So thank you very much for this opportunity to present what I think is probably the most critical aspect of research on rare diseases, and that is to establish collaborative partnerships with all the partners that are required to make things really move forward with rare diseases and orphan products, because without those partnerships, we just don't move nearly as quickly as what we should or could. So thank you very much. And I'll stop sharing and send it back.
Thank you, Steve. Very quickly, you gave us the entire world. You spent more than 35 years in rare disease area. Nobody ever done that much. And we thank you for sharing your knowledge, and particularly for IORD, you have been so helpful to us from the day one we started this. Thank you so much. Your message is very clear. I hope India will get to the point where you want us to be. Thank you very much for taking your time to come here. Thanks, Steve. Now.